Thank you. Thank you, Adam. Thank you, the organizing committee of the ACSM for inviting me. And also I want to start by highlighting the presence of our students at Hofstra University. This shows not only eagerness to learn, but also they are here to present as well. So that's a very good first step in their career as a PT. Our research study was targeting the training of the gluteus maximus muscle using a standardized program called POWERS program in patients with low back pain. And we did this in collaboration with researchers from Egypt. So it was multimodal study, when partially was done here, and also other part was done in Egypt. So why chronic, and why it's called chronic mechanical low back pain? So first of all, you all know that low back pain is very prevalent, right? And it's one of the main causes of diseases in adults. It is estimated that 50 to 80% of adults will experience low back pain at some point in their life. And we call it mechanical because it's due to mechanical causes, not due to diseases. So mainly postural dysfunction, muscle imbalance, assuming bad posture for a long time, and all these kind of stuff. But it's not related to diseases per se. Like it's not inflammation or infection or tumors or all these kind of stuff. So it's only we're addressing the mechanical cause of low back pain. And it's defined to be chronic if it persists for 3 months or more. So the treatment options that are available out there is either surgical or non-surgical. So the non-surgical treatment that we're talking about today, one of the non-surgical intervention that we can talk is exercises. And by addressing the muscle that might be contributing to the low back pain, we might get rid of the pain or even a little bit decreasing the intensity in some instances. In order to understand the connection between the Gmax, the gluteus maximus, and the low back pain, we have to understand the different function that the gluteus maximus muscle is doing for the lower extremity. For me, this is the most important muscle in the lower extremity just because it has multiple functions in maintaining the posture and preventing the trunk from excessive rotation and forward bending. So let's first understand the function of the Gmax. So the Gmax will function in open chain, like when your leg is off the floor, to perform abduction of the hip, extension of the hip, and external rotation of the hip. Not only that, just because some of the fiber of the Gmax will attach here to the medial femoral shaft, and these fibers will also perform the adduction of the hip when you are in open chain. So we'll bring the hip from abduction to adduction. Also, the Gmax will provide this active tension over the sacroiliac ligaments, mainly the sacroiliac and sacrotuberous ligaments, when you lean forward to kind of prevent you from excessive bending of the trunk, and also provide the stability over the pelvis to kind of link it to the spine. And in doing so, the active tension of the Gmax together with the hamstring and the paraspinal will actively tensioning the sacrotuberous ligaments when you lean forward to kind of compress the sacroiliac joints in place, maintaining its stability. Not only that, so it's important function in stabilizing the pelvis, it's also preventing the adduction internal rotation moment of the femur in closed chain positions. And this is very important because adduction internal rotation is one of the causes that will produces anterior knee pain or patellofemoral pain syndrome. So by providing this external rotation to the femur, it will prevent this patella from going inward, squinting, or going into internal rotation of the femur, causes anterior knee pain. Also, this muscle, because it's a strong hip extensor, it will also prevent you from excessive leaning forward of the trunk, and also working with the opposite latissimus dorsi, the lat, it will provide it would prevent you from excessively rotating your trunk, so preventing further damage if you twisting the trunk. And this is called the posterior oblique sling or the posterior oblique system, that when the gluteus maximus contract with the contralateral latissimus dorsi, it will prevent you from excessive trunk twisting. So giving the importance and highlighting the multiple function of this muscle, you see how it's important in maintaining the biomechanical alignment of the lower extremity and also preventing excessive damage to your trunk. It has also function in gait. So in gait, when we walk the G max in the heel strike phase, so in heel strike, what is it? So in heel strike, this muscle will contract eccentrically to prevent excessive trunk leaning, right? And produce this stability. And then in mid stance, the muscle will contract concentrically to maintain the stability over support. And then during the terminal swing, this muscle will again contract eccentrically to kind of decelerate the femur, the hip, from going into too much flexion moment, and then prepare you for the second step. All right. So the exercises, so in order to train this muscle, you have to train the triplanar movement of extension, abduction, and external rotation, right? So we need to address that when you strengthen the gluteus maximus. And then because this muscle is so important in lower extremity, Chris Powers, who is a PT from California, he was the president of the California Board of Physical Therapy, and also he's the chair of the physical therapy program at USC. He was talking a lot about the importance of gluteus maximus in maintaining the biomechanical alignment of lower extremity, and then he developed this program which carries his name, Powers Program, and in this study we studied that program in specific. So in this program, it has 8 phases. Phase 1 to 3 is just activation of the muscle. What is activation? Activation is a weak muscle that has been sleeping for a long time due to inactivity or weakness or better competency. So you want to reactivate this muscle. This is the first 3 phases of this program. And then phase 4, 5, and 6 is going to be 4 and 5 going to be G-max strengthening. So strengthening is providing some exercises to improve the power of this muscle. And then the last 3 phases, 6, 7, and 8, is going to be functional, advanced functional and agility training exercises. Right. So in this program, the patient has to attain and achieve the goal of the phase before progressing to the second phase. Right. So these are some of the exercises that Chris Powers described. So when we activate the muscle, like for example in clamshell or fire hydrant position, supported fire hydrant position, the aim of the exercise is to achieve the contraction for longer time. So the ultimate goal is to hold the end position for at least 1 minute. But you're not going to start with your patient holding the end position for 1 minute. You have to build up to that because the patients might be weak at the beginning. You just can allow 5 seconds and then build up to 1 minute at the end. The idea is to progress to the second level when this level is attained with the band's resistance, right? And then phase 4, 5 is going to be your strengthening exercises. So the goal here is to achieve the repetition, like 2 sets of 15 or 3 sets of 30. 3 sets of 10 to kind of maintain the repetition to kind of gain the strength against resistance. And then phase 6, 7, and 8, this is going to be your advanced sports training. And I'm pretty sure that sports athletes will do these at some point in their training. So give you some example. The cutting, the zigzag running, and also the single leg jumping over hurdles. This is going to be your advanced exercises in this program. And this is not going to be for older folks, right? This is going to be for a younger population like us who have low back pain. Right, so that's being said, and the importance of this muscle in specific, we conducted a study to investigate the effect of gluteus maximus strengthening and activation using POWERS program on patients with chronic low back pain. Our design was a double-blinded randomized controlled trial. What does this mean is both the investigator and the patients does not know what's going on. To kind of improve the internal validity of the study, the research assistant was responsible for collecting the data, and the patients were blinded to the group allocation. Patients were told that they're going to receive 2 different types of treatment for low back pain. To determine how many patients we need, we ran something called sample size calculation. When we input like numbers into software, and this software will give us the estimated sample size. So we ran the sample size using a software called G-Power, and we used an effect size of 0.8 with a power of 80% and margin of error of 0.05. For our students, what does this mean is the effect size is the minimal effect that you want your treatment to detect, and then the power is the strength of your study. Like if you repeat this study over and over again, you want to make sure that 80% is going to be the treatment effect, and then we have to put like 5% margin of error. Our participants were middle-aged population, 21 to 45. They were referred to us with chronic low back pain over than 3 months, and with a BMI between 18 and 29.9, and back disability index, the Oswestry was less than 30. That's because patients with severe low back pain will not be able to progress through this program. We excluded patients with pain due to specific pathologies like infection, tumors, osteoporosis. We excluded post-operative patients, patients with lower extremity injuries in the past 6 months, and patients with severe symptoms of the ODI, the Oswestry, if it's more than 30, the score of more than 30, and then if they have associated lumbar instability or spondylolisthesis. We screened, since we needed 52, we screened 78 participants, excluded 29, and then randomized 52 into 2 groups. One group received the POWERS program in addition to a conventional treatment of flexibility exercises, TENS, and hot backs. And then the other group, the control group, received only the flexibility and TENS hot backs. So this group B, served as an active control, meaning they received treatment, but they still a control since they didn't receive the treatment of intent, which is the POWERS program. We lost 2 individuals in each group to the follow-up, and then we ended up with having 48 participants analyzed in the statistics. So Group A received the 8 phases of the POWERS program progressively, and they received also, in addition to that, flexibility exercises, hot backs, TENS for 12 sessions, 3 sessions per week for 4 weeks. The other group, the Group B, the active control, just received the conventional treatment only, without the POWERS program. Our primary outcome measures was to measure the pain and the function, so like to see how much pain before and after the treatment, and the function, disability function using the Oswestry, the ODI. The secondary outcome measure was to assess the gluteus maximus strength using a handheld dynamometer, and also to assess the functional performance using a standardized HOP testing. So in the assessment procedure for pain, we use the visual analog scale. This is very common and very commonly used in research. And the VAS is 10 centimeter line, where the patients just mark on the line, and then we measure with a ruler how much is the distance from 0, and then we round it up. So if we have a distance of 4.7, we round it up to 5. The pain is 5 out of 10, and so on. And we measure this before treatment and after treatment. And the VAS has a good psychometric properties in chronic musculoskeletal condition, right? And then for the functional disability, the ODI, the Oswestry, The Oswestry, if you guys familiar with it, is 10 items questionnaire where the patients choose the best response that best describe his condition on a Likert scale from 0 to 5. And then the total score is 50, and they multiply this by 2 to get a percentage. It's important to say here, if you have a person who's not an adult, you have to use the modified Oswestry because section 8 will ask about sexual life, and if you're using, if you're treating a minor, you have to use the modified version where this section is replaced by homemaking, not the sexual activity. So it's at 10 questions, scoring from 0 to 50, and then multiplied by 2 to get the percentage score. And also it has an excellent psychometric properties. All right, so if one of the sections, the patients used more than one answer, the highest answer was chosen for statistical analysis. For the strength, this is the secondary outcome measure. We use the handheld dynamometer to measure the strength. The patient assumed a prone position, and the dynamometer was placed above the popliteal fossa. And then we tested the isometric contraction, the mean of 2 trials, and the patients hold the contraction for 5 seconds. And then also the handheld dynamometer has excellent psychometric properties. For hub testing, we use the standardized hub testing of noise, and I'm pretty sure the athletes in research using this a lot to standardize the return to function after the treatment, right? So hub testing has 4 separate tests: a single leg hub for distance, a triple hub crossover, and then metered hub for 6 meter. In this study, we only used the second and third one, which is the triple and crossover hub, just because these two simulate the level 6, 7, and 8 in the POWERS program. Oh, let's go back. All right. So for the single limb triple hub test, the patients hopped 3 times over a single leg, and then we measured the distance, right? For the crossover hub test for distance, also the patients use a single leg to cross over zigzag hub, right? And then also we measure the distance. And for the treatment, we provided, as we said, 2 kind of treatment: the POWERS program and the conventional treatment. For the conventional treatment, it was just like kind of flexibility exercises, stretching the tight muscles, providing tents for pain, hot packs for pain, and then gentle isometric exercises. And this served as the conventional control, right, the active control. And the treatment was provided 10, if it's resisted, 10 repetitions for 2 sets, or the heat pack for 10 minutes, 15 minutes for the tens. For the POWERS program, we applied the 8 phases of the POWERS program using 3 different level of resistance: yellow band for light resistance, green for moderate resistance, and blue for high resistance, high resistance. And as we said, we have to attain the goal of each phase before progressing to the next phase. Meaning, if I'm going to do a clamshell in phase 1, I will have to progress to a fire hydrant in phase 2 after the patient attain and maintain the 90 seconds, 60 seconds hold at the end of the fire hydrant range, right? And then the second phase, the first 2 weeks, we applied the activation and the strengthening, and in the last 2 weeks, we progressed the patient into the functional training in the 3rd and 4th week. So these are some of the exercises we performed. So for the clamshell, the patient assumed a side-lying position against resistance of the bands, and the end position was held up to 1 minute before we progress to the second level. The fire hydrant, we did the fire hydrant in standing, supported standing, and also unsupported standing to kind of progress the patients from level 1 to level 3. And in level 2, we did the squats and the surfer exercises. Also, again, making sure with each of these exercises the patients will perform extension, abduction, external rotation to kind of get the muscle activated. And then progressing to level 4, we did the crab walking, and I've seen people doing crab walking in clinic. Just make sure when you do the crab walking, the patient has to step out and backward a little bit to kind of get the hip into extension, and then pointing the knee out to kind of get the external rotation component. If the knee does not go into external rotation and the patient just moves the leg to the side, the gluteus maximus is not going to be maximally recruited. You have to point the knee out as you push out and pushing on the floor to kind of get the extension, external rotation of the leg. And that was done also using resistance bands. For level 5, we did the split squats and single leg squats, also using first without resistance bands and then with resistance bands. And then level 6 and 7 and 8, we did these exercises to kind of simulate the functional training that we did using functional assessment using noise, hop tests. So forward jump and lateral jump, the single leg forward hop testing exercise, and then the cutting or zigzag jump. All right, so these are the phases, these are the treatment that we provided in group 1 and group 2. So the results shows the following. So within group comparison, meaning the achievement of the treatment outcome in each of the group pre to post. So group A pre to post, group B pre to post. Both group pre to post treatment shows statistically significant difference in all the outcome measures: pain, function, gluteus maximus strength, and functional performance. But when we performed the between group comparison, that is comparing group A to B post treatment, only the group which received the powers program showed improvement in gluteus maximus strength, and with no significant difference between the groups and the other variables. So there was no significant difference between the groups in pain, function, or the functional performance. Only the group that received the powers program showed slight improvement in Gmax strength. And we can discuss, based on the results, that the higher improvement in Gmax strength observed in the study group is likely to be attributable to beneficial effect of the powers program, since we have a partial area square of 24 to 26, which is a moderate effect size, to kind of conclude that the effect was due to the powers program. And this finding corroborates a prior systematic review done by Fowl et al., which confirmed that the hip muscle strengthening contribute to reduced pain and disability in patients with low back pain. Santa Maria et al. Also performed another systematic review. Their group investigated the effect of hip muscle strengthening on pain disability in patients with non-specific low back pain, and they found that hip strengthening shows moderate benefits for function, but the evidence for pain was inconsistent throughout the research. And this helps explain why our study found robust strength gains, but no pain improvement between groups. Another study, to kind of link it to our study, which is Kuzo et al. 2025, this is one of the recent study. They studied the effect of adding aerobic exercises to core stabilization in patients with, these are older folks though, in patients with low back pain. They found that adding the aerobic exercises to the core stabilization in these population led to superior improvement in functional capacity and physical performance compared to core exercises alone. And this supports the inclusion of Gmax strengthening in rehabilitation program of targeting chronic low back patients. It's important to note here that the strength gain does not necessarily translate into improvement of function. So you might have patients improving in muscle strength, but the pain is still there. And this is what happened in this study. The pain didn't improve significantly. It might improve clinically, but like not to the point that shows statistical significance. And that's probably because pain is also modulated by other factors like central sensitization, fear avoidance, and psychological factors. These factors will require longer multimodal approaches to treatment. Right? So since our study only ran for 4 weeks, that probably was not enough to detect improvement in pain. One other study, which was last year, the investigated effect of gluteus maximus strengthening exercises in patients with low back pain, quality of life, and they found that these patients significantly improved in pain, function, psychosocial measures, but this contradicts our results because our results didn't show that result, didn't show the same results, but their study ran over longer time, and then they used multiple program in treatment. In 2009, Stefano published this great study where they ran an EMG analysis of the gluteus maximus and gluteus medius during various therapeutic exercises. And they came up with a conclusion that the best exercise to strengthen the gluteus maximus are the single leg squat and single leg deadlift. And the best exercise to strengthen the gluteus medius was the side lying hip abduction. And this study is important because they used the superficial EMG on the muscle, and they detected the muscle activity during various exercises. So the limitation of our study is, for me, the main limitation is the lack of a true control group. When you run a research and you don't have a true control, you cannot really be sure that the effect was due to your treatment. It might be due to other factors. Since the other group received treatment already, you cannot really make sure that the study group improved due to the POWERS program. And also, the treatment was conducted over short duration with no long-term follow-up. We cannot really measure the long-term effect of the program so far. The sample size was relatively small, and this will limit also the generalizability to all the population. So we can conclude that the 8 phases of the POWERS program improve the Gmax strength in subjects with chronic mechanical low back pain, while the effect on pain, disability, and functional performance didn't show much difference between group. Also, POWERS program should complement, not to replace, the existing multimodal graded exercise. But just to summarize in a nutshell, exercises are one of the modalities that received high evidence in clinical practice guidelines. Not specifically POWERS program, but exercises in general. So when you treat patients, it's not only the modalities that will get you there. You have to put your hands on a patient, do some sort of manual treatment and exercise in order to gain results. These are some of the references, and good news for me and for my research group that the study is almost published by a Q1 journal. They asked us to just revise the manuscript and send them back by November 17 in order to be published. So hopefully you can see this published soon. Thank you so much.